Is the recording going? Yep. Okay, I see it. Perfect. Good morning, everyone. Thank you for joining our Oregon Health Policy Board educational webinar this morning. The topic for today is the Basic Health Program, and we are joined by several members of the Basic Health Programs team. We have Nikki Olson, Laurel Swerdlow, Tim Sweeney, and Katie Waldo. And the team will be presenting specifically on expected marketplace impacts of the Basic Health Program. And before we get into their presentation this morning, I just wanted to remind everyone that today's educational webinar is for informational purposes only, and no health policy board decisions will be made today. Today's educational webinar is to support everyone's education and support the board in making their decision at the September board meeting on the blueprint. So today we will prioritize members' questions about the topic, and those questions will be taken at certain points throughout the presentation at the end of each section. So we ask that members please hold your questions until the end of each section, and then those questions will be addressed. And today's recording will be posted on the Oregon Health Policy Board's website later today or first thing in the morning. And we just ask that if there are any questions or comments, those go to me. So members, please use the chat feature for that. And without further ado, I'll turn it over to the Basic Health Program team for today's educational webinar.
Thanks, Tara. And can we go ahead and get the slides going? While they're coming up, I just want to say good morning and welcome again to today's webinar on the expected Basic Health Program impact on marketplace consumers. My name is Laurel Swerdlow. I use she and her pronouns, and I serve as the Basic Health Program project lead. I'm joined today by our policy lead, Tim Sweeney, and our managing sponsor, Nikki Olson. We've got a lot to cover, so I'm going to go ahead and dive right into the next slide. Our goals today are to understand how the Basic Health Program, or BHP, is expected to impact consumers above 200% of the federal poverty level who remain on the marketplace. We'll discuss the three main ways folks who remain on the marketplace will be impacted by the BHP. What consumers pay for their marketplace premiums will increase for most marketplace consumers. Increases will vary based on age, income, and plan choice, and are expected to be greatest for consumers at or above 400% of the federal poverty level. In response to these premium changes, some consumers, an estimated 1,800 consumers, will choose to drop their coverage. However, most consumers will respond to these premium changes by either staying on their plan or switching to a different marketplace plan. And we'll dig into these three impacts later on in the presentation. Then we're going to walk through the options that OHA and DCBS have explored so far to mitigate this impact and help improve marketplace affordability, along with the options that are still on the table. I'll note that last week, board members made a couple of requests to better understand what the Basic Health Program will cover. We tried to fit that information into this presentation, but ultimately we were unfortunately incapable of doing so within the hour allotted for this webinar, which again is intended to really dig into the BHP impact on marketplace consumers. So instead, we'll be following up within the next several weeks to respond to the questions posed regarding the Basic Health Program coverage itself. Next slide. So first, some background on the current state of the marketplace and what a Basic Health Program is. Next slide. Eligibility for OHP, Oregon's Medicaid, varies based on age and health needs. OHP covers a robust set of benefits at no cost to enrollees, and most adults are eligible for OHP up to 138% of the federal poverty level. Thanks to the Affordable Care Act, most people not eligible for OHP can purchase coverage through the Oregon Health Insurance Marketplace. Most marketplace consumers are eligible for financial assistance in the form of what's called cost sharing reductions and or tax credits to make coverage more affordable. Next slide. A quick note about how consumers access marketplace coverage, because it'll become relevant when we eventually discuss solutions to mitigate the BHP impact on marketplace consumers. Oregon consumers currently access individual marketplace plans through what's called the Federally Facilitated Marketplace, or FFM, which is operated by the federal agency CMS. Folks commonly refer to the FFM as healthcare.gov because that's the domain used to shop plans. However, in 2027, Oregon will transition from healthcare.gov to what's called a state-based marketplace. And this will create greater flexibility for Oregon on lots of fronts. And we'll discuss later how it will open doors for future opportunities to improve marketplace affordability. Next slide. Marketplace health plans are categorized into metal levels, bronze, silver, and gold. Metal levels reflect the amount of premiums and cost sharing, a term to refer to costs other than premiums, such as copays or deductibles. Bronze plans generally have the lowest monthly premiums and the highest cost sharing. Gold plans generally have the highest monthly premiums and the lowest cost sharing. And silver plans are generally somewhere in the middle. Next slide. So historically, people who are just above the threshold for OHP, folks who are 138 to 200% of the federal poverty level, have had the lowest insurance rate as compared to the rest of their counterparts on the marketplace. As you can see here in a 2019 survey, we found that 91% of consumers on OHP and 90% of consumers above 200% were covered by insurance, compared to 82% of folks in this 138 to 200% category. Next slide. But this was actually a statistic that changed during COVID. Due to federal regulations during the public health emergency, states like Oregon were not allowed to disenroll people from Medicaid. And what we saw is that continued access to no-cost coverage vastly improved the coverage rates for people 138 to 200% of the federal poverty level. Acknowledging this, the legislature passed House Bill 4035 in 2022, which directed OHA to create a permanent coverage solution for this population. Next slide. A task force was convened in 2022, which recommended that the state pursue authority under Section 1331 of the Affordable Care Act to establish what's called a basic health program. Basic health programs exist to cover this exact population. States must apply to the federal government by submitting what's called a BHP blueprint. And states that do receive federal funding to cover individuals up to 200% FPL who would otherwise be eligible for subsidized marketplace coverage. Next slide. So the Affordable Care Act actually gives states considerable flexibility regarding what can be covered on a basic health program using federal dollars. But instead of offering the bare minimum, Oregon is deciding to go on the opposite side of the spectrum and cover the most expansive benefit package possible within available funding. It will cover the CCO-administered OHP service package at no cost to the enrollee. And as a result, it's estimated to cover over 30,000 folks whose needs would not otherwise be met on the marketplace. Next slide. I've sort of touched on this already, but we want to clarify that the timing for setting up the basic health program now is really important. Beginning in April, those continuous coverage requirements that I referenced earlier began to unwind. Over the next year, states throughout the country are undergoing what's called Medicaid redeterminations, in which we are redetermining eligibility for everyone currently covered on Medicaid. In Oregon, that means 1.4 million folks currently on OHP are undergoing redeterminations. On the other side of those redeterminations, we estimate that about 300,000 folks will no longer be enrolled in OHP and transition to other types of coverage. Given that historically we know that this 138 to 200% FPL population falls through the cracks, Our goal is to create a new program that will make sure this population is able to continue to be covered. Next slide. So the BHP is currently scheduled to launch in July of 2024, and coverage is estimated to slowly ramp up over the subsequent 3 years. 55,000 people currently covered by Medicaid who are 138 to 200% FPL will transition to the BHP immediately when it launches. Actuaries estimate that about 11,000 folks who are currently uninsured will eventually choose to enroll in the BHP. And then lastly, almost 36,000 consumers currently purchasing marketplace coverage with income 138 to 200% FPL will move to the BHP gradually over the course of 3 years. This transition of folks from the marketplace to the BHP is expected to impact those consumers who remain on the marketplace, which Tim is going to discuss in greater detail now. But before I hand it over to him, I'll pause here and ask if anyone has any clarifying questions regarding what the BHP is or the role that it will play in the coverage patchwork here in Oregon.
Thanks for that, Laurel. And I'll just clarify that because of the tight time we have together, we are prioritizing questions from members.
Thank you. Yeah.
And I know a couple members will be watching the recording, so I don't see any hands up or any chats from members. So let's keep going.
Great. Hello again. For the record, I'm Tim Sweeney with the Office of Health Policy at OHA, and I'll go over this next section. So for the next slide, this next section is going to chat a bit about the impact that creating a BHP will have on marketplace consumers. And again, as Laura just mentioned, these are folks with income above 200% of the federal poverty level. And really this analysis focuses on people who are eligible and receiving federal tax credits, federal subsidies towards the purchase of their marketplace coverage now. Next slide, please. So before diving into the data, I want to provide a high-level overview. We've gotten some questions about this from members. A high-level overview of the modeling work performed by our outside actuarial consultants at Oliver Wyman. At a high level, what they have is a micro simulation model that forecasts consumer behavior in response to various healthcare policy and program changes. They've used this model customized to state level specifics, population, demographics, et cetera, to help a number of states analyze and predict the impact of healthcare policy changes, especially those in pursuit of federal waivers. The BHP is not exactly a federal waiver, but this is really sort of part of the intent of this model, is to be able to predict the impact of policy change like this. In terms of analyzing the impact on the individual health insurance market of creating the BHP, this process on the right here considers both sort of static as well as dynamic changes. For instance, the analysis first starts by removing the BHP cohort, people with income from 138 to 200% of the federal poverty level, from the marketplace enrollment, from the marketplace population, to determine then the population of consumers that remain on the marketplace. After removing this population, the model revises premium rates to reflect the changing population, if they're healthier or less healthy, for instance, as well as in this case, the loss of what's called silver loading, which we talked about before and I'll allude to again in a moment. And at this point, the model sort of runs dynamic changes as consumers respond to price changes, and kind of repeats this cycle over and over until the simulated market reaches stability. And that's sort of the output of all of this. In short, I mean, this model allows actuaries to examine the projected impact of policy with the results based on how consumers respond in real life. Micro simulation just means that we're looking at the response of micro levels. We're looking at the response of consumers. We're not looking at the systemic response. This model really enables us, again, with data based on how consumers actually respond in real life, to project how consumers will respond to various policy changes. So now getting into the results of the modeling, and the next slide shows at a high level, the summary is somewhat simple. Broadly speaking, most consumers with income over 200% of the poverty level will experience modest premium increases beginning in 2025. Premium increases will vary based on income, and people whose income is higher than 400% of the poverty level will experience the largest increases. People whose income is lower, closer to 200% of the poverty level, will experience smaller premium increases. In the wake of these premium changes, some consumers will respond by shifting behavior. For instance, the modeling estimates that about 1,800 consumers will decide to drop their marketplace coverage between 2025 and 2027. On the other hand, still, the large majority of consumers who get subsidies on the marketplace will stay in the marketplace, though some are expected to switch plans in response to these premium changes. Most likely switching from more expensive gold plans to less expensive silver plans, but there could be other changes embedded in there as well. Now, I'm going to go through these high-level conclusions in a little more detail, and the next slide shows, starting really with the first one, starting with a discussion about the cost increases that consumers will experience. So on the next slide, in order to really examine the expected premium changes, I want to start with an overview of how federal tax credits offset monthly health insurance premiums for most consumers, and that's on the next slide here. So based on a person's income, family size, and the cost of silver plans in their area, consumers may be eligible for federal tax credits that offset some of their monthly premium. This is depicted in this graphic by the lower section. And then the upper, the darker, not shaded areas represent the consumer portion of their monthly premium after accounting for this federal tax credit. As shown here, people can use this federal tax credit towards any plan. But if gold plans are more expensive than bronze plans, for instance, their premium, the consumer portion of their premium, will be lower for bronze than for gold, and we can see this relationship. This graph is not reflective of any specific region or age, but rather intended to visualize the role of tax credits offsetting a portion of premiums, and really, I think, highlights the fact that the portion of premiums that consumers pay is both a function of the overall premium set by the health insurance carrier, as well as the value of the tax credit that they're eligible for. And this latter point really is relevant for the next part of the conversation, because what's happening after the BHP is created is actually that the value of the tax credits change, less so the underlying premium. So if we were to change this graph, it's that shaded area that is changing, not necessarily the size of each bar. So with the next slide, we'll talk a little bit more, hopefully at a very high level, about what's happening, because the why here really is a bit complicated. However, in short, right now, federal tax credits are actually larger than normal for a couple of reasons. One is because the federal government put in place enhanced tax credits in response to the COVID pandemic that boost the value of tax credits for consumers across the income spectrum. But a second reason is based on state policy changes in response to federal funding cuts that happened in 2017. The state policy response is called silver loading, which again is fairly complicated, but the end result is that it effectively increases the value of tax credits that people are eligible for, increases tax credits compared to pre-2017. Removing the BHP population from the marketplace, moving the folks with income between 138 and 200% of the poverty level from the marketplace into the BHP essentially means that this practice has to go away, which will reduce the value of tax credits for consumers whose income is above 200% of the poverty level, causing the consumer portion of premiums to increase for most consumers. The impact to individual consumers will vary depending on their age, their income, and their plan selection choices. For instance, people enrolled in silver plans may not will not experience much of an increase at all, while consumers who choose gold plans right now likely experience the greatest increases. It's also worth noting that these premium increases won't be fully felt in 1 year, but will be spread over the course of 3 years, again, beginning in 2027. So spreading through 2020 or beginning in 2025 and through 2027, sorry. And lastly, it's worth noting that most consumers will be experiencing premium increases that are broadly on par with increases that occur every year in the marketplace. Marketplace premiums are always fluctuating, and in many cases, consumers are somewhat practiced at shopping around for plans in response to those fluctuations. So now that we've gone through a little bit of the context as to why that's happening, we can pivot to looking at some of the data points to help show what is expected to happen. And so this next chart, this next slide, starts a series of charts that show the number of people who are expected to experience premium increases of various amounts. And this is starting with 2025. So here we see that the most common premium change is a monthly increase ranging from $1 to $25 per month, and that's the bar that is 32,410 people. So the most common experience for consumers receiving subsidies is a premium increase in this range, and that's 32,000 out of the approximately 86,000 consumers who we expect to receive subsidies on the marketplace in 2025. Another 23,000 or so consumers have no premium impact or a net decline in premiums. This could be because of plan choice decisions. So that's the two bars on the left added together, while about 29,000 people would experience an increase greater than $25 per month, again, in 2025. So moving forward to the next slide shows 2026, and we can see similar numbers of people experiencing increases of $25 or less. But as the increases phase in, there are more people whose total premium impact is larger. I want to pause here and also note that the increases in 25 and 26 shown on here aren't additive, but rather that the cumulative increase over multiple years reaches the higher number. So this is not showing that 32,000 people had a potentially $25 increase in 25 and then another $25 increase in 26, but that the blue bars now represent the cumulative increase felt by consumers through both years. Now going through the next slide, we can see 2027, and the trend continues as more people do experience greater than $25 premium increases than did in 2025. However, still the most common cumulative increase after those 3 years is still no greater than $25. So there's still a heavy concentration in those lower three categories. Looking at this a little bit differently, the next chart shows only 2027 the full extent of the premium impact, and we can see a little bit more about the distribution across these changes. Still, nearly 60% of the by 2027, it's more like 90,000 subsidized enrollees. Still about 60% or so experience premium increases of no more than $25. However, about 14,000 people will have had their premiums increase by more than $100 cumulatively over these 3 years. So moving on to the next slide, as mentioned at the beginning of this section, premium increases are partly a function of income, and higher income consumers will experience larger increases than lower income consumers. And this slide really shows that by showing the average premium increase broken down by age and income cohorts. As you can see, the average increases for people with income between 200% and 300% of the poverty level are much smaller than for consumers whose income is above 400% of the poverty level. And we have a little chart on the left to show what those poverty level thresholds mean. For instance, at 300% of the poverty level, an individual would be at about $44,000 annually, and a family of 4 would be at about $90,000 annually. Also, for reference, about 44% of consumers receiving subsidies on the marketplace have income between 200% and 300% of the poverty level. That is the largest of these 3 income cohorts, while about 26% have income over 400% of the poverty level. And partly that is a function of the subsidy calculations. People whose income is above 400% of the poverty level are less likely to qualify for subsidies than folks between 200% and 300% of the poverty level. So shifting gears a little bit, the next slide, we can move back to this conversation about the consumer response to premium increases. And as we mentioned a couple times, the analysis estimates that about 1,800 consumers above 200% of poverty will drop coverage in response to these premium increases. So the next slide puts that in some level of context. First, this 1,800 figure represents about 2% of the subsidized marketplace consumers with income over 200% of the poverty level. And while this is not a desirable outcome necessarily, it's worth putting this figure in context. At the same time as these folks decide not to purchase coverage on the marketplace, OHA expects that more than 30,000 people would be covered by the BHP who would otherwise end up uninsured. This figure is really made up of folks in 2 situations. First, the Oliver Wyman modeling estimates, as Laurel mentioned, that approximately 11,000 people who are currently uninsured would enroll in the BHP, as the program's lack of premiums or other member costs would be attractive to more people. Second, OHA estimates that the BHP will prevent coverage loss among 20,000 people or more who would otherwise end up uninsured following the OHP redetermination process and getting disenrolled from Medicaid, that they would end up uninsured instead of enrolling in the marketplace. And this would be prevented with the BHP because instead of being disenrolled from Medicaid, they would be transferred directly into the basic health program. This estimate is based on some national estimates of coverage losses at a state level in the wake of the public health emergency unwinding process, and actually assumes that Oregon would do a much better job than the national average because of the intense effort by marketplace staff and by the Medicaid system to connect people to marketplace coverage if they lose Medicaid. But still, as that data at the beginning shown by Laurel about coverage for the 138 to 200% population historically, it's expected that not everybody would transfer to coverage. So in short, coverage losses would be greater without a BHP than they will be with the BHP. Lastly, one or two more slides here, and then I can finish. A bit about people switching plans in response to premium changes. So the next slide, please. Broadly speaking, switching plans is one way consumers respond to premium changes among marketplace plans from year to year. In response to the changes we've highlighted, we expect consumers in gold level plans may be most likely to switch plans. And still, people weigh out-of-pocket costs as well as premiums when choosing a plan, and many people may be willing to pay more for better coverage despite the premium increases, which is really why many folks would be expected to remain in their gold plans. And so the next slide shows the cumulative enrollment changes across metal tiers. And these numbers represent the overall change in bronze, silver, and gold enrollment among marketplace consumers whose income is more than 200% of the poverty level. So in 2025, for instance, 500 more consumers in this income range are expected to choose silver plans compared to 2024, while 2,100 fewer people will choose gold plans. Moving into 2027, the full impact of the BHP is seen in the numbers, and across 3 years, the modeling suggests that silver enrollment will increase by about 3,400 members, while gold enrollment will fall by 4,800 members, and bronze enrollment a very slight decline, mostly as it stays about where it is prior to the implementation of the BHP. And with that, that is the end of this section. I'm happy to take any questions that board members may have.
Great, thank you, Tim. Well done. Those charts just explaining the different federal poverty levels and impacts to individuals and families is so helpful for me. So great job, team. All your work on these. And I see member John Santa has his hand raised. Go ahead, John.
Thanks, Tim. So this is helpful and interesting. I'm left with the impression that one of the factors causing this is that the population that is lower income that will be attracted to BHP has higher subsidies that actually to some degree cross-subsidize to those higher income populations. And that that's why their departure removes you know, a bit of funding from those plans. You know, because I'm just, as you were talking, I'm trying to figure out these sorts of things always involve a transfer of resources from one source to another. And it seems like the way the marketplace program was structured, actually the lower income folks, to some degree, it looks like, subsidized the higher income folks. Is that an accurate statement? And if so, is that the way the federal government set it up? I mean, was their intention for this to work? I'm sure they've seen these numbers. Was their intention for it to work this way?
So this is a great observation, Dr. Santa. It's absolutely right that this is effectively what's happening here. And I don't think that it would be right to say it's the intent of the overall structure of the ACA, but this is maybe an unintended consequence of the silver loading policy that we alluded to, that most states implemented in response to federal funding changes. And so it has kind of been in some ways a positive accident for folks with income over 200% of the poverty level, that policy change effectively sort of cross subsidizes their premiums to make coverage more affordable for them. And we're seeing the drawback being that making policy change to make coverage then more affordable for folks with income between 138 to 200% of the poverty level has ripple effects beyond that population. I know Katie Button from our marketplace is also here. I don't know if she'd like to speak more to sort of what's happening here, and sort of how this affects consumers on the marketplace. But
thanks, Tim. Hi, everybody. I'm Katie Button. I use she, her pronouns. I'm the plan management analyst for the Oregon Health Insurance Marketplace. I would just add that it's not that the consumers who will leave for the BHP are subsidizing the rest of the folks on the marketplace. But when you silver load, your options are either that you can silver load or you can broad load. So if you broad load, that means all the plans have an increase. So that would mean actually that folks on the marketplace subsidize the folks who are eligible for CSR. So when you silver load, what you do is actually just protect everyone from having to subsidize the folks with the CSRs, and you put it back on the federal government. But then, like Tim said, the unintended consequence is then that everybody gets more tax credits, which is great, until something happens like the BHP and you need to pull people out. And so then all of a sudden this extra money is like that was given to folks as a technicality ends up going away.
Okay. So, I mean, the federal government is allowing the BHP to occur to their credit, and they're funding it to occur. But it's been their decision that they're not going to change the way the marketplace is structured in response to what they're doing. And so the fact, I think I kind of understand silver loading. The fact that in the current marketplace structure, the best strategy is to silver load. It brings the most dollars to the most people, but then when a segment of those people leave, it causes the problem that we're seeing. Is that correct?
That's right. And I think the next section also gets into some of that conversation with the federal government about the barriers to doing something about it. But yes, that structure is what's causing this this issue.
Okay. And now, I mean, Oliver Wyman is a established and credible actuarial firm. CMS considers the work that's been done here to be incredible, credible work that's in the mainstream of a micro-stimulation actuarial model, et cetera, right?
Yes, and we have shared with this analysis with them really at every turn, and they have broadly supported the conclusions and think that the work has been, I don't know what the word is to say, like, yes, to your question. I mean, they're a great firm, and have done this work for a lot of states to understand the impact of a variety of policy changes on marketplace coverage and consumer response.
Okay, well, I appreciate this section, and it responds to some of the information that I asked for. Thank you.
Thank you.
Tim and Laurel, thank you so much for the presentation thus far. The slides are very helpful, kind of really understanding better what the situation is now. So I do have a question around, what is, and I know you're going to send additional materials and answers later to the board. So maybe some of this can be covered when you do that, because I know we have more slides and we're running out of time. But one of the questions that I'd like to know more about is what is being lost from folks who go from gold to silver, right? Like, what are the big pieces of coverage that are being lost when they make that switch? And then also, what additional impacts will there be in the marketplace once you go from, basically having folks being shifted into that silver category? So are we expecting like additional impacts once folks go from like gold to silver?
I
Yeah,
think you can answer that at
go
a
for
high
it.
level here. Go ahead, Tim.
Yeah, I was just gonna say, I mean, it is, I think the second piece is captured in the Oliver Wyman analysis, in a sense of they run these simulations and the markets sort of get to a new equilibrium, and any premium impact of more people going into silver and fewer people going into gold gets run through the model, so we see the continued impact of that in these numbers. So there's nothing sort of like not seen or not modeled in that. As far as the individual consumers go, I mean, I think it's tricky to say in some level what the results will be of somebody picking a silver or a gold plan. I think the fundamental nature of this model is that it models consumer behavior in a rational way, that like somebody is going to smartly choose a silver plan because the lower premium is more valuable to them than the higher deductible, somebody who doesn't use services quite as much, and that folks who are willing to pay the extra $100 a month to stay in a gold plan are doing so because the lower deductible or the lower out-of-pocket costs are more valuable to them than saving some money on premiums. And so I think that at a high level, this incorporates that consumer decision for what is best for their situation, to have lower premiums or lower out-of-pocket costs.
And I'll just again at a very high level, Oscar, what's happening here is people are weighing premiums against out-of-pocket costs. And they're deciding, you know, it might actually be better for me to pay a lower monthly premium, even if it means that I might have slightly higher cost sharing, because I don't use my plan as much as other folks who might choose higher premiums in order to have lower out-of-pocket costs. So it's really, again, as Tim was saying, the model attempts to emulate a rational consumer weighing premiums against out-of-pocket costs.
Okay, thank you.
Great questions, Oscar and John. I do not see any other member hands raised or chats from the members, so let's go ahead and keep going.
Sounds good. I should be able to get us through this last section with some more time for questions. My name is Nikki Olson. I use she, her pronouns. I'm, as mentioned, the managing sponsor of this work. If you go to the next slide. As has kind of been referenced, developing this coverage solution for the 130 to 200 over the past year and a half has been happening in tandem with exploring different approaches to addressing marketplace affordability and kind of assessing that impact that we just walked through. And the state's really kind of seen these as equally important efforts and have been working really diligently in the past 18 months to do so. So we wanted to spend a few minutes just offering up some additional detail on the challenges faced and the strategies that we've explored to date to improve marketplace affordability, but how that is what we've learned through that is redirecting our efforts, and we're going to continue exploring opportunities. So we're going to talk through that. Next slide. So as I mentioned, Oregon spent 18 months exploring pathways to specifically federal funding, receiving funding to address these gaps, or these changes, I shouldn't say gaps, changes we've seen in an effort to shield consumers from premium increases that we just discussed. The main learning from this effort is that without a state-based marketplace, so essentially the place where people go and shop for this coverage, none of the pathways for federal funding were operationally feasible. So that is that CMS could not support the changes that would be needed on the federally facilitated marketplace for the ideas that we explored. And some good news here is that Oregon's moved to a state-based marketplace by plan year 2027, as directed by the legislature in the past session. That will provide important flexibility that we need in overcoming some of these operational barriers. So that's good news for 2027. That opens up, again, this ability to look to federal funding options for the state for that year. But in the meantime, we're going to continue to work with carriers to explore essentially state-funded stopgap solutions that could really help address plan years 25 and 26. Next slide. So I'm going to offer up some more detail about this journey, but really that last slide kind of gives you the most critical takeaways on this effort. So just kind of taking a step back and to attempt to simplify at a high level what barriers we faced when we looked to federal funding and the federally facilitated marketplace to operationalize the different ideas. There's essentially three variables that kind of drive feasibility. One is just the basic concept of implementation. How do depending on the strategy, the question is, how do we get the funds to the consumers or the carriers to reduce costs? The second is communication. If we're going to have a subsidy available to consumers, for example, how do consumers that are shopping on the FFM know that they might be eligible for additional subsidies, especially if you're tailoring those subsidies to certain populations who are impacted most? In our case, the FFM could only support a simple banner that would tell people something exists. And we really were concerned about how much confusion this could cause, and it's just insufficient information to guide consumer purchasing. And finally, kind of the biggest piece is the funding source itself. So the different waivers available to draw those federal funds down to the state have a lot of ways in which they're restricting the ways that the money can be used and the ways that you would design the different strategies. So on the next slide, again, we're just staying pretty high level here, but we wanted to just give a scope. We've mentioned these in more depth in previous presentations, but the options we've explored with the federal government and with carriers to date include a state administered subsidy program, which would effectively be to create a subsidy that would be tailored ideally to different populations impacted most, that would kind of serve to further reduce their premium costs. We explored a second strategy that we call gold benchmark. It's related to the silver loading concept, but it would essentially increase the amount of tax credits consumers receive, and that would be happening more behind the scenes, so to speak. And it wouldn't require any complex additional subsidy to operationalize or communicate about. But this strategy did require that CMS make back-end changes to the FFM that they were unwilling or unable to make. And finally, a third strategy, something we would refer to as a BHP lookalike. It's an alternative way to get federal funds and design something that's like a BHP. This path was explored because having an alternative to Section 1331 that we are pursuing for the BHP would just open up some more options. But ultimately, there's a different formula when you take this path for calculating funding for the state to run the program. And the funding calculation for this idea would result in essentially greater risk to the state and insufficient funds to operate the program, let alone draw down more funds for a subsidy. So it was explored because of other barriers, but it itself didn't really present a viable, affordable solution. Next slide. So if it isn't clear yet, the key takeaway here is that really having to rely on federal funding, which is ideal to be bringing in federal funding for this, and relying on the FFM just has Oregon facing insurmountable barriers, especially for now plan years 25 and 26. Like I mentioned, the FFM could not administer a subsidy or communicate effectively to consumers about that available assistance, and CMS was unwilling to prioritize all the changes needed to the FFM to implement the gold benchmark strategy. And ultimately, with the federal waiver policies, it really has impacted in some ideas how much funding is ultimately available, or there were too many restrictions on how we could apply the funding to make it effective. Next slide. So probably pretty clear at this point that to address marketplace affordability, Oregon needs to move beyond federal funding and reliance on the FFM. We've done the analysis to understand how the premium increases will play out over plan years 25, 26, and 27, and walked us through that in detail. So we know we can explore different strategies for these years. We're looking to develop a stopgap solution for 25 and 26, again, continuing to work with carriers, and ultimately hoping to open back up federally funded solutions that we can operationalize through a state-based marketplace in 2027. So the next steps involve us to continue to work with carriers. We have been hosting what we refer to as carrier tables for the past year and a half, talking about all these ideas with carriers, inviting their suggestions for ideas and solutions. And we want to continue these conversations, but now we're really intentionally making this shift to say, is anything operationally feasible that we could then look for non-federal funding sources, and really kind of removing those restrictions that have come through those paths. So we're really hoping to be working as quickly as we can to some solutions to start looking ahead for those future years. And that, I believe, concludes all the content we have for today, and we still have some time for some questions.
Great. Thank you so much, Nikki, and the entire team. I see John Santa has his hand raised. Go ahead, John.
Yeah, thanks. This section just made me think. I assume there's been some discussion about, well, what might be the reaction to the private side, carriers not in the marketplace, who see a segment of the marketplace population potentially interested in a lower priced product. Could that scenario happen where another carrier offers individual insurance, with a less rich benefit plan that wouldn't conform to the marketplace rules, and could be offered cheaply? Is that a possible scenario?
I both went off mute at the same time to see who would be the other. You go for it, Tim?
Well, I was gonna defer a little bit to Katie Button. I believe that they still have to meet essential health benefits for off marketplace coverage, so there would still be some limits to that, like, less generous piece of your question there. Is that right, Katie?
Right. All individual market coverage has to be ACA compliant. And then we have actually all of the individual market carriers offer through the marketplace. So they do offer some off-exchange plans, but they can't be significantly less expensive than what we offer already.
Okay, so that the private side is going to be precluded from, if you will, trying to take advantage of this situation, and all. Okay, thanks.
Great questions, John. If any other members have questions or comments, please feel free to raise your hands and in the chat or unmute yourself. But since we do still have a couple more minutes of this morning's educational webinar, are there, any other bits of information that the team would like to share that maybe we didn't get to quite touch on or want to go over again?
I wanted to circle back to Oscar's question just to make sure that he felt like that was sufficiently answered. I feel like it was really a core question that he asked of what happens, kind of what is the impact on consumers who shift plans. And I wanted to check in, Oscar, to feel if you really got your answer there.
Kind of. Thanks for like circling back.
Yeah.
I mean, it sounds like folks will be making tailored decisions that are relevant to their own situation. But I mean, I just want to know, like, is there a huge, what is, like, are they losing? What are some of the things that they would be losing from having to make that choice of going from gold to silver?
Yeah. And I think at the core of your question is, like, will they be losing coverage, or will they simply be paying more? Is that kind of at the core of that question?
Or will the quality of their coverage,
Exactly,
will they not be able to get the level of care needed? I think I was wondering if there's a little bit more along the lines of the coverage experience rather than the cost.
But
yeah,
can you go ahead?
Yeah, basically what Nikki is saying.
Button, could you explain a little bit at a high level the difference between a silver plan and a gold plan?
Sure. First, I would note that there are people right now who are enrolled in gold plans that cost less than silver plans. So some of these folks moving from gold to silver are actually just looking and saying, I pay $100 right now for this gold plan, and now the gold plan is $150, but there's a silver plan for $100. So they're, like, actually staying in the same premium. They're just moving to the silver plan. we work really hard in Oregon. Most of our plans offer significant office visits ahead of deductible. So like I'll use the standard plans for an example because all of the carriers offer those. So on the gold plan, the office visit for PCP level visits is $20, and on the silver plan, it's $40. So if you are someone who doesn't use significant things that would hit deductible like inpatient care, then those office visits, yes, you pay a little bit more, but the premium amount you save on the silver might really be worth it. And so when folks are looking at things, that's kind of what they're looking at.
Thanks, Katie. And just to kind of clarify that, it sounds like it's the same services that are being covered, but there's going to be a different cost in the deductible that you're, or excuse me, the copay at the office. So it's like pay now or pay later, so to speak. Or
it's all
like,
pay now. It's just how
that.
much you pay at the point of visit. So the gold plan's $20, silver plan's $40, the bronze plan's $50. But the premium amount you save, which is something that you have to pay every month, might really drive you to the lower tier plan because the amount that you save on premium is going to make up the amount that you would pay in cost sharing.
And I think what I imagine Oscar's wanting to know too is if we have people moving from gold to silver as something we're observing in the modeling, are we going to see unmet needs start to occur, or folks not being able to access certain types of services because they are no longer on a plan that, you know, the question here is like, is it substantially different in what you actually get access to? And I think the answer is no, but that's why it's yours up and not mine. So
correct. Yeah, the answer is no. It's not a change in the services or a change in the quality of care. It's just going to be a change of your premiums and how much you and your cost sharing. And I'll just once again reiterate that you know, due to 2017 federal cuts in funding, Oregon did this thing called silver loading. And what it's caused is folks have changed the plans that they choose because they have more tax credits than normal. And so what will happen when we establish the BHP, those tax credits will go down and they're going to go back to the plan choices that they were making before those federal cuts happened in 2017.
Thank you.
Okay, thank you.
Yeah, thank you. I think now that we've heard the message several times, several different ways, it's really sinking in. So thank you for being patient with us. I see we're just about at time, but I see John has his hand up. So John, why don't we go ahead and hear from you and go over just a couple moments here?
Yeah, I don't need an answer, but you know, as I mentioned previously, does the Wyman model include impacts that other things Oregon is doing may have, like, you know, with the waiver, children are going to have longer eligibility and continuous eligibility. Women are going to have eligibility for, you know, a year after they deliver. You know, I would just assume that, you know, there is some reflection of those things. That's all.
Yeah, I mean, just to quickly answer you, I don't think that it would be fair to say that those like waiver provisions have a ripple impact into the Oliver Wyman model. Like how it would be very small, like how many kids are going to stay on Medicaid and how many of them would have moved into the marketplace as opposed to say moving into employer coverage or whatnot. But though there weren't variables for those two policy changes included in the modeling. It really was intended to be a status quo, like this is what the market will look like without the BHP, and this is what it will look like with the BHP, to really isolate the impact of the BHP and not confound it with the impact of lots of other changes that may or may not happen in that could affect the health insurance market, really to isolate the impact of this policy change specifically.
Great. Thank you again, Oscar and John, for your questions. And thank you to the team, plus Katie, for jumping in here and helping to answer questions. I know at the beginning of the educational webinar, Laurel shared that there were a couple of questions from the July board meeting that the team will be working on to get that information to members, and we'll also share that under the meeting materials for the July on the board's website. So thank you, everyone. And again, this recording will be posted to the board's website later today or by tomorrow morning. Just thank you for your participation and all the hard work in this topic. So everyone have a great day, and thank you for your time this morning. And take care, of course.